Okay, and we're live. Welcome back, everyone, to another virtual shouting session at Hearts for Health. We're excited that you could join us on this Monday evening. I hope y'all have started your summer off well. Hopefully, this is a good start to your week. So today, we're going to be joined by Dr. Chen. He is a double board certified emergency physician in emergency medicine and medical toxicology. He'll be talking about that specialty today. And I do have a few reminders before we do get started with his presentation. So especially if you're new to our virtual shouting program, I want to kind of acclimate you to our typical structure. At the very end of each of these sessions, we do have a Q&A, usually 20 minutes at least, where we'll go through any questions that you have in the chat. That chat is either to the right or the bottom of the live stream that you're looking at right now. And you can type in your questions at any point in time. We'll go through them at the end, like I said, but we do accept them at really any point in time during the presentation. One last reminder I do have is if you would like to stay tuned with more sessions. So we typically have sessions on Mondays and Thursdays at 7 p.m. Central to discuss specialties like medical toxicology and more. We have a lot of subspecialists on and also specialists on to talk about really anything to do with medicine. For those of you who might be pre-dental or pre-PA, we do have a couple speakers here and there, especially during the summer. We do have some scheduled. So we do cover really almost all pre-health fields if you're not necessarily pre-med. And that really is all for reminders. If you do want to keep in touch with us in terms of what or when we have our future sessions, then you can feel free to join our listserv, which is on our website. If you go on to our really any page and you go on to the last or the bottom of any page, you will find our subscription form. So if you subscribe over there, put in your name, your email, you'll be good to go. It's just a weekly email with the flyers that you see on Instagram. We also have them there. So those are two ways to go about staying tuned with things, through Instagram or through our listserv. If you have any questions, feel free to email us. Our email is community@hearts4health.org. We can take any questions about our shouting program, about our mentorship program. We have a couple other volunteering programs. So we're happy to take any questions there. But I don't want to take up too much time. So Dr. Chen, feel free to take it away.
All right. Thank you, Michael. So as Michael mentioned, my name is Richard Chen. I am a board certified emergency medicine physician and medical toxicologist. I am part of the Jefferson Einstein Medical Center Network. And what we're going to be talking about is how I came to become a medical toxicologist. So this is just a really quick basic outline. We'll kind of just go really quickly over who I am as a person. Talk about my journey to becoming a medical toxicologist, then go and talk about what medical toxicology actually is. And then I have a couple of cases to discuss and kind of go over to kind of give you a taste of some of the things that we might deal with as medical toxicologists. So that's me. Like I mentioned, I'm double board certified emergency medicine and medical toxicology. I am currently a core faculty member at the Einstein Medical Center in Montgomery emergency medicine residency, where I guess I'm the quote resident toxicologist there. I am also a father. I am a gamer as well as an avid CrossFitter. Just to kind of show you that many doctors do have a lot of hobbies that you may also have, even though a lot of the stuff that we do might seem kind of crazy. So the question is, how did I get here? And it's I think a little bit of an interesting journey. So all started, as you guys probably already know, in order to get into medical school, you have to finish college first. So I actually attended Johns Hopkins University, where I obtained a Bachelor of Science in Material Science and Engineering. So this was obviously 4 years. When I first entered into undergrad, I wasn't really sure if I wanted to become a doctor. I had a couple of high school friends that were talking about becoming pre-med. I did not go into college thinking I was going to be pre-med, but about a year in, I decided that I did want to pursue that. And so fortunately, my degree course requirements had some overlaps with the pre-med requirements. So after finishing my degree, well, I guess the year before, I was applied for med school for the class that was beginning in 2010. Unfortunately, despite getting some interviews, I got no acceptances and just a couple of waitlist offers, and then ultimately did not get any offers after that. So I ended up taking a detour, which I think you'll find is becoming more and more common among a lot of physicians and people who go to med school. And so that first year off, I completed my master's degree in the same field, material science and engineering. So that was 1 year. And then I ended up doing an internship at the Army Research Lab at the Aberdeen Proving Grounds in Maryland through OVERISE. And so this was completely non-medical. It was more of a wanted to do something for a year, kind of explore, see if medicine actually was something I wanted to do, because not getting in kind of made me take a step back and really reflect, like, was this really what I wanted to pursue, or should I just go and take my degree and go do something else? And so I did stuff like ballistic testing, and saw a lot of different, more traditional aspects of engineering, if you will. But ultimately, I did decide that I wanted to go to medical school. And so I applied again. And this time, fortunately, had a little better luck. So more applications. One thing I do recommend for those of you who are trying to get into medical school or PA school or whatever it is that you decide to do is that to stay on top of the applications, submit things as early as you can. The timing really does help a lot. So this cycle I applied, basically submit all my applications right around when they opened up, and got significantly more interviews, and then got a couple of acceptances. And I ultimately decided to attend University of Maryland School of Medicine. So this picture is from the white coat ceremony that took place after our first exam as a first year. So just to real quick go through, so medical school, as many of you probably know, is very intense. It's probably one of the I consider to be one of the most intense periods of my life. It's one of the periods of time where I probably worked the hardest I've ever had worked up to that point. So there's a lot of studying. Years 1 and 2 are consistent of lectures, small groups. You get some intro to clinical skills and clinical medicine. And then after you finish your second year, you take your USMLE Step 1, which is the United States Medical Licensing Exam, which is a requirement to pass in order to kind of continue your training into becoming a physician. Year 3 is typically when people start doing their core clinicals. So things like internal medicine, general surgery, et cetera. And then this is kind of the year where you kind of figure out what do you want to do when you grow up, meaning when you graduate medical school. And so year 4, you do some away rotations, you do a bunch more electives, and then this is also when you apply for residency, and then you take step 2 during this time at some point and hopefully pass. And then match day happens in March, and then you graduate. And so for me, emergency medicine was not really on the table in the beginning because my engineering background, I actually wanted to do orthopedics. But unfortunately, my step 1 score was not the best it could have been. And so that ended up kind of changing, making me reconsider what exactly I could actually get into in terms of a residency program, given that orthopedics is extremely competitive. Ultimately, I think that ended up being like everything turned out for the better. Emergency medicine is great. I love the specialty. And then it allowed me to kind of discover medical toxicology. So even though you may not do great on an exam or something, don't think that it's the end of the world. There's always alternatives. There's always another path. And sometimes bad things happen for good reasons. And so once I applied for residency, I ended up matching into emergency medicine at Rutgers Robert Wood Johnson Medical School. And so this is a 3-year program. There are a few 4-year programs for emergency medicine. I decided to go with a 3-year program, partly because I had a feeling that I wanted to do a fellowship. I knew that I wanted to go into academic medicine. I felt that a fellowship at some point would help me differentiate myself from my other emergency medicine colleagues. And so I did not know up to this point when I was entering residency that medical toxicology existed or was even a subspecialty of emergency medicine. It was fortunate that my program had a toxicology rotation. We had a medical toxicologist on staff. There was actually a toxicology service. She saw consults. And so that helped me discover that subspecialty of emergency medicine. So residency, for kind of just quickly go over that. So when I was at Robert Wood, the shifts were all mostly 12 hours. Just like with other emergency medicine programs, you go through various rotations to kind of get experience in critical care, pediatric emergency medicine, anesthesia, et cetera. You had your weekly conferences, which is where you get the bulk of your lectures and learning about all the stuff that you need to know to become a competent emergency physician. And then every year during residency, you would have your in-training exams, which is basically like a mock written boards to kind of see where you're at in terms of your knowledge base. And we were told at least that there is correlation between the ITEs and or your chances of passing your written boards once you graduated. And so after you graduate, you then can take the qualifying exam to become board certified. So the qualifying exam is just the written exam or written portion, which is step one in terms of passing your boards and getting certification. And then once you pass those, then you go on to take your oral boards, where you basically have oral boards cases. You have a proctor that walks you through a case, and you basically tell them what you'd like to do, and then you get scored based on that, and then pass or fail depending on if you do things correctly. So in terms of timeline, so I graduated medical school in 2016. So then I graduated residency in 2019. And so, like I mentioned before, I knew I wanted to do a fellowship. I was still trying to figure out at the end of second year what exactly I wanted to do. But because I had this new experience with medical toxicology, I sat down and talked with the faculty member who was a toxicologist to kind of discuss and what it was like and that kind of thing, and made a decision to apply. And so in terms of applying, at least at that time, there weren't as many people trying to pursue medical toxicology. So the process was a lot less stressful as compared to residency. And so it was not as, I did not feel as concerned or worried because part of it, I had done some electives rotations with some of the programs, and one of the programs had basically said that if you want to come here, then just rank as high and everything will be good. I can't say that that's the case now. It's definitely become a little bit more competitive. A lot more people are kind of a lot more residents, emergency medicine residents, are discovering like what medical toxicology is, the benefits of fellowship, and also the job market was not great over the past couple of years, partly because of COVID and a lot of different factors. And so a lot of people were looking to fellowships as a way to potentially delay having to search for a job and end up with no job. And so we have definitely gotten many more applications for fellowship as compared to when I applied. When I applied, I think I was maybe like one of 4 people, but at least the past couple of years, we've had we've interviewed like 10 to 15. And so at least at Einstein, we have 2 slots per class. So once I got into fellowship, I was supposed to do fellowship at Hahnemann University Hospital. For those of you who are not aware, Hahnemann Hospital closed because the owners of the hospital basically filed for bankruptcy for the hospital. And so I didn't find this out, or basically nobody found this out until it was on the news about a month before the new academic year. And I was sort of in panic mode because I was like, well, I want to do fellowship. What am I going to do? And fortunately, Einstein, which is also located in Philadelphia, picked me up and saved me, as well as my senior fellow, who was also at Hahnemann. And so what was training like in fellowship? So fellowship is 2 years long. That's something to kind of take note. There are a lot of fellowships, at least subspecialties in emergency medicine, that are only 1 year. So it is a big commitment, particularly if you completed a 4-year program. because it is an additional year compared to something else that you might be able to go to fellowship for. So it's something to kind of think about. In terms of the daily schedule, most days basically in the office, Monday through Friday, 9 to 4 p.m. So kind of more of a office-like job. And basically you would be on call based on some schedule, rotating with the other fellows. And you would take call and then seek consults within the Einstein network. So either at main campus, which is the one in North Philly, which is where the division and the fellowship is sort of based, as well as Elkins Park and Einstein Montgomery, which sometimes you would have to drive to those locations. In addition to taking call for the hospital system itself, you would also take call for the CHOP Philadelphia Poison Center. And so that was all phone consults. So you basically would get contacted by the C-SPY, which is the nurse or pharmacist who's the certified in poisoning information. And they would call you and let you know there's a case at this hospital and they wanted to talk to the medical toxicologist on call. And you basically discuss the case. And so with that, you kind of get a little bit more exposure to more cases outside of what you would see at bedside at the home institution. Research and academic productivity were also obviously a big part of fellowship, just as it probably is for any fellowship. So wrote case reports, did research, went to conferences, etc. During this time as well, the attendings would help the fellows develop and improve teaching skills. And so kind of create a collection of lectures that you can use later on as an attending if you need to give a lecture. Tox fellowship, some of my attendings kind of jokingly call it a reading fellowship. It is a lot of reading. Actually, do I have, so the textbook, one of the textbooks that we use is Goldfrank's, and you can see that that is a very thick book. Unlike some other classes where you might use a textbook, you're only responsible for maybe like part of the content. We are responsible for knowing everything that is in this book in terms of for board exams and also for clinical practice. Some stuff is going to be a little bit more relevant to sort of day-to-day practice, but in terms of what we're supposed to get out of fellowship, that is sort of what the expectation is. And so that's also something to kind of consider in terms of it's basically going back to med school, except now you're getting into really nitty-gritty pathophysiology and whatnot. And so after making it through those 2 years and graduating, the board exam is administered every 2 years on the even years. And so it was just administered last fall, which is when I took it. So when I graduated off cycle. So I graduated in 2021. And so I had the additional year to kind of study. If you graduate on cycle, then you would basically be expected to take it in the fall. In terms of, you basically get two chances before you are no longer board eligible, and you have to go through like a remediation because your board eligibility lasts for 5 years. And so because it's only given every other year, you unfortunately only get 2 chances as compared to like emergency medicine. I believe that board eligibility is also 5 years, but it's offered every year. And so you get a little bit, a few more tries out of that if at worst case scenario. So now that's kind of how I became a medical toxicologist. So your question now might be, what is medical toxicology? And so I'm going to just start out with the definition that's provided by our professional group, the American College of Medical Toxicology. So medical toxicology is a subspecialty of medicine focusing on toxicology and providing the diagnosis, management, and prevention of poisoning and other adverse effects due to medications, occupational and environmental toxicants, and biological agents. So what that basically means is that medical toxicologists deal with overdoses, whether these are overdoses on illicit drugs or prescription drugs or over-the-counter medications. We deal with medication adverse effects, including ones that are caused by various drug-drug interactions. And these may also be unique or rare side effects for these medications that may not be commonly seen. We'll deal with addiction medicine. So we do a lot of medication-assisted treatment. Occupational exposure. So this includes the gambit of any of those chemicals that you might see in industry, whether it's used for manufacturing, could be some sort of fuel, etc. Basically anything that somebody could be potentially exposed to while working in industry. We are the experts in that field. Environmental exposures and envenomations. So these include like poisonous plants, mushrooms, venomous snakes, scorpions, jellyfish, pufferfish, you name it. If it's got a poison or a toxin, then we probably have some familiarity or knowledge about it. And then lastly, we also are sort of the look to experts for chemical and biological warfare. So these include things like sarin gas, VX, mustard gas, as well as botulism, ricin, and other biological agents. And so what can you do once you become a medical toxicologist? So you could be like me, and this is what typically most medical toxicologists will probably end up doing. Doing academic and clinical medicine. But you can also go into industry and do consulting, so working for a pharmaceutical company or other company that requires a medical toxicologist. Occupational medicine, go into doing addiction medicine, work at a poison center, work for governmental agencies like the CDC, and then you could also just go and do research of some sort. And so in terms of typical schedule for me as an attending, the day usually starts around 9 o'clock. And then basically when I arrive, we sort of have some pre-round discussion about cases that are on the service. The fellows let me know what's going on. In terms of at least the way it works at Einstein, the attending changes basically every day, depending on how the schedule sort of formatted. Sometimes an attending might be on for a couple of days in a row. But a lot of times, at least for me, because I'm not on service as much, it might have been a couple of weeks since I was last on service. So the fellows kind of update me on what's going on. Usually the fellows will pre-round before this, and then we go and round in the hospital between 9 and 11. Usually there's somewhere between like three to 7 patients on service, depending on how busy it is. After we get back, we do some teaching for rotators. So these include med students and residents. And then either that later that morning or in the afternoon, we do more fellow specific teaching. So talking about a chapter from Goldfrank's or one of the other textbooks that we use, and then kind of helping them figure out or basically plan their eventual board studying plan and what kind of stuff do they need to know and focus on. Depending on the day, there might be a national case conference or webinar from one of the professional societies. So ACMT being the American College of Medical Toxicology, or AACT is American Academy for Clinical Toxicology. And then like I mentioned before, I do some addiction medicine. So I am one of the attendings that staffs the medication assisted treatment clinic once a month. And so I have patients that I'll see if it's on that day. In terms of other things that I do, so as I mentioned, I'm a core faculty member for the residency program at Montgomery. So there's a lot of resident teaching and lectures and stuff from that point, a lot of responsibilities from the standpoint of being a core faculty member. I've also been a reviewer for institutional grants and the resident research competitions in-house at Einstein. I'm part of the Toxismo webinar committee, which is basically a webinar where we discuss either classic or new research articles in toxicology. I'm a reviewer for various academic journals, as well as for our national conferences for ACMT and AACT. I'm also Stat Pearl's editor and author, and then also a content writer for an online course. So you can kind of do a lot, and especially with having that background in medical toxicology, sort of bring expertise to the table. So a lot of people want you to contribute to whatever they might be planning. And therefore, the expertise that you bring can be very, very helpful. So that's kind of it in terms of talking about my journey in medical toxicology. I guess we're doing saving questions to the end.
Yeah, we typically save questions to the end, but this might be a good stopping point, maybe just for a couple questions, if you don't mind.
Sure, yeah.
So earlier you mentioned that you had your degree in engineering for undergrad, right? Do you see your degree in engineering crossing over to your practice in medicine? Because I know, especially lately, there's been a couple schools that have promoted, an engineering-based medical school curriculum, or at least have had masters in engineering along with their MD.
So I think the biggest part is that I guess I've seen a lot of the content and stuff that I was exposed to as an undergrad and learned about popping up in sort of the stuff that I need to know for medical toxicology, particularly in the occupational medicine aspect. So things like polymers and resins and semiconductors and all this stuff. When we would talk about these chapters, I noticed that I had a little bit more familiarity and knowledge compared to some of the other fellows because of my background. I think that's probably the biggest part where I've seen. And so it really helped during fellowship, as well as helping me retain knowledge and things a little bit better because I already had that familiarity, sort of the kind of following on the stereotypical thing where repetition is sort of what begets expertise. And so having already seen that content, it kind of helped me be able to direct my brain energy toward other things that I may not have as much familiarity with. So definitely helping with management of the content that I'm responsible for.
Yeah, that is an advantage right there. That's a great advantage to know. Another thing is you mentioned addiction medicine, occupational medicine being a couple of things that you work with in terms of career outcomes as a medical toxicologist. We wanted to ask, do you collaborate a lot with addiction psychiatrists in that sort of realm?
Yeah, so at Einstein, at least, there is a very close working relationship between psychiatry and toxicology in terms of establishing protocols and how exactly they want to approach management of these patients. I guess offhand, I don't know how many of those psychiatrists are actually addiction board certified. But yes, there is definitely that interplay for sure, because they sort of help a lot with the mental illness aspect of a lot of these patients do suffer from. And they also bring their own degree of expertise and knowledge from a different perspective, where we kind of approach from sort of like the pharmacotherapy mechanistic kind of aspect. The psychiatrists sort of bring in the sort of from the angle of mental illness and how to treat all that stuff.
Yeah, it is interesting to see specialties kind of coincide and collaborate. And one more question before we move on to cases. You mentioned that another career outcome is working for governmental agencies like the CDC. So along with that, could you possibly work on the front lines in the Army, being a medical toxicologist, or is it mainly mainland where you would work?
So I don't have a definite answer to that. I'd have. I've interacted with a lot of people who are from the Army, and so there's a couple branches there's one that does research with chemical weapons and their effects and how to manage that, as well as like biological weapons. And so I know that they have medical toxicologists who are enlisted, but from my understanding, in terms of like being on the front lines, I think the Army, sort of as a overall governmental agency, probably does not want to put resources like that on the front lines where they potentially could be harmed, just from a like strategic point of view, because that person has been invested in them, and they can bring their expertise by helping develop protocols and things like that, that those on the front lines can then use to help manage chemical weapon exposure, biological weapon exposure, that kind of thing. But in terms of working in the Army, that's 100% definitely either as an enlisted member or as a civilian. It kind of just depends on which route you're kind of going. I guess if you were in medicine through one of the military branches, then you would probably be able to, you could probably find some pathway where you could become a medical toxicologist, but then be enlisted and then kind of figure out how you want to incorporate that kind of thing into your practice.
Sounds good. Well, I think that's all the questions that we'll have for now.
Okay. All right, so we'll jump into some case discussion here. And so this first case, it's exploratory ingestion gone wrong. So basically, there's a 21-month-old female, has medical history of rickets and vitamin D deficiency. The mom had just filled a prescription for an iron supplement early in the day for the child. And somehow the patient had managed to drink the entire bottle about 1 hour prior to arrival. So the mother had called the poison center and they instructed her to come to the emergency department for evaluation. Just prior to them presenting, they had already been noted to have decreased responsiveness and have vomited 3 times. And so I can tell you that just kind of preface that that's never a good thing immediately after if somebody's been exposed to a medication and had overdosed. So their initial presentation, they were afebrile, so the temperature 36.4 degrees Celsius. Their heart rate was 130 beats per minute. Blood pressure was 117/60, and they were a little bit tachypnic at 36 breaths per minute. The patient was sort of evaluated initially by the emergency team, and then we kind of came into the picture not too long after because of sort of the inciting event. So the patient was lethargic. They were kind of responsive to voice and physical stimuli. They're kind of open their eyes, but then they're kind of go back to being really sleepy. One thing that was very concerning is that they didn't cry when the nurse placed an IV. Typically, most kids will cry if you place an IV or do anything that hurts. So that was not a good thing. Their pupils are about 4 millimeters. They were reactive. They were otherwise like regular, tachycardic, no other abnormalities on heart exam. Lungs were fine. Abdomen was fine as well. And so for this particular presentation, I mean, typically we always kind of want to keep that differential broad, but the history sort of told us like, this is what's happening, that the patient had overdosed or drank a bunch of iron supplements. And so the question is like, what do we do now? And so because of how lethargic the patient was, the emergency room team intubated the patient for airway protection. Labs were obtained, and then we got consulted to help sort of assist with further management. And so these are sort of the labs that they had. So we obtained a venous blood gas, which is a test that can be used to check your pH of your blood, as well as your CO2 levels, and kind of get an idea of whether somebody is potentially very sick or not. And so a pH of 7.27 is a little bit on the lower side, not super critically low, but much lower than would expect for a otherwise healthy young child. We had sent off acetaminophen, salicylate, and ethanol levels. Those were undetectable. And the patient's labs were notable that she did have an anion gap of 21. So the pH of 7.27 with an anion gap of 21, she was developing an anion gap metabolic acidosis. And so her iron level was 314 micrograms per deciliter. And so this was not quite, I guess, what would be considered quote, toxic levels, but clinically she was displaying a lot of signs of severe toxicity, namely that she was starting to develop an acidosis, she was lethargic, all that kind of stuff. And so our recommendations as toxicology were to attempt to do decontamination. And so whenever we are considering management for a patient, there are 3 major things that we consider. We consider whether there's anything we can do to remove the source of the xenobiotic, and so a decontamination of some sort. So whole bowel irrigation, active charcoal, NG aspiration. We had recommended, because this was a liquid formulation, that they attempt to place an NG tube and then see if they can aspirate anything out of the stomach. And then we recommended they then perform whole bowel irrigation. And this is basically in the in the off chance there's still something left in the gut that could be absorbed, and we could prevent it from being absorbed, and so potentially prevent more iron from being absorbed. We recommended that they administer the antidote for iron toxicity. It was a deferoxamine. And so this is essentially a chelator. And so it basically goes in and binds up all the free iron in the serum so that it can't go and interact with tissues and cause damage. And with iron, there is no specific way to enhance elimination. And so we didn't necessarily recommend anything from that perspective. And so Einstein, the way our health system is set up, we don't have any inpatient pediatric services. And so this patient ultimately was transferred to CHOP. They fortunately ended up doing well. They remained intubated for another 24 hours before they were successfully extubated. They remained on the deferoxamine for that 24 hours as well. And you can kind of see the trend of the iron levels here. Went from 314 down to 50 before they stopped it. Patient was in the hospital for an additional 2 days, and they were discharged with no apparent neurologic sequelae or issues. So fortunately, this patient ended up doing well, probably because they presented early and we were able to sort of administer all the appropriate interventions to prevent any badness. So talking about iron toxicity, so iron itself, as many of you are probably familiar with, is used for mainly the treatment of anemia. It's found in a lot of different supplements. It can be found as a supplement on its own, as well as in multivitamins, most notably prenatal vitamins. When determining how or the potential for toxicity from a particular formulation, you had to look at and see what type of iron is contained within that supplement. The most common is ferrous sulfate. And when it comes to iron, we care about how much elemental iron is in a supplement. And so specifically ferrous sulfate, which is the supplement that this child had ingested, contains about 33% elemental iron. And so then we take that information based on the total amount that they took, take 33% of that, and then that's how much elemental iron they took in. And then in terms of determining whether that ingestion is potentially lethal, we look at the elemental iron dose and divided by how much they weigh in kilograms. And so you can see the ranges here. You expect mild to moderate toxicity with 20 to 30 milligrams per kilogram ingestion, severe with greater than 40, and then anything greater than 60 is potentially lethal. And if someone were to swallow a bunch of like multivitamins, the tablets can actually show up on X-ray because they are radio opaque. So that's another way to kind of another investigation that I can perform to see if there's anything in the gut still that can be absorbed. So iron toxicity, we generally divide into 5 stages. Your stage 1 is your GI toxicity, and this is what sort of manifests immediately. So within 30 minutes to up to 6 hours out. Patients then enter what we call a quiescent phase. So it's a stage where the nausea and vomiting and stuff sort of improves. They look like they're getting better. But if you were to check their labs, you could actually start seeing some signs of organ damage. Stage 3 is where the patient starts being more systemically ill. And so outwardly, clinically, they'll look ill. This is where you get more liver damage. You start developing acidosis. And then this will then progress on to stage 4, where patients then can go into hepatic failure. And so this occurs somewhere 1 to 2 days post-ingestion. And so this is sort of that point in time where patient can either then survive or go on and die. And so stage 5, patients don't enter that stage unless they recover from the initial acute toxicity. The main problem in terms of long-term sequelae from iron toxicity is the formation of GI strictures. Because iron is very irritating to the stomach, it can cause damage to either the stomach or the esophagus or the small intestines. and basically cause over time scar tissue, and then you can get a stricture, which then that obviously will present as complications with swallowing and bowel obstruction and that kind of thing. So I had mentioned before that the iron level that we had gotten on this patient wasn't like a super high level. So you can see that typically you would expect only GI toxicity with 300 to 500 micrograms per deciliter. Any ingestion that results in an iron level that's less than 300 micrograms per deciliter is usually non-consequential. They usually will do fine. And then you can see that greater than 1,000, there's a very high rate of mortality associated with that. Our main concern with this patient, despite her level being okay, was how fast she sort of developed symptoms, as well as the fact that she already had an acidosis. And given that the amount that she ingested was potentially lethal, given her weight, we decided to kind of go with more aggressive treatment to prevent anything from worsening. And so the main treatment for iron toxicity is deferoxamine, which is a chelator for iron. It's derived from this bacteria, Streptomyces pilosis, and basically combines with iron and forms ferrioxamine, which then is just eliminated by the kidney, so you pee it out. And so sometimes on exam for these patients that you give this antidote to, you can see what we call vin rosé urine, and basically have kind of like a pinkish reddish hue to the urine. Generally speaking, criteria to give this antidote is the patient looks critically ill. So they are lethargic. If they are hypotensive, so their blood pressure is low, or if their serum iron level is greater than 500, regardless of whether they're having symptoms or not. And that's the structure, that's the ferrioxamine structure. So I think it's a pretty cool molecule because deferoxamine itself is a very long chain, and it basically kind of wraps itself around the iron because of the multiple oxygens that are present in deferoxamine, and basically forms this cage around iron. And so I think it's I think it's kind of a nifty reaction, if you will. So for our second case, so I have two cases where this one was a diabolic grin. And so this case was a 72-year-old female. She had presented for an allegation of confusion, but when EMS kind of called ahead, so this is a patient that I saw in the emergency room as the emergency physician, as the primary emergency physician. The medics had said that she was, quote, clenched down, and I wasn't really entirely sure what that meant. But when the patient arrived, the patient wasn't speaking, she was clenching her teeth, and she had muscle contractions all throughout, so increased muscle tone. And unfortunately, the other complicating factor is that the patient only spoke Mandarin, and the family had not arrived yet. But from what we got initially from the medics is that the patient had taken a supplement around 4 p.m. She arrived around 7 p.m. and was noted to have these symptoms about 30 to 45 minutes prior to arriving at the emergency department. The medics said that the family told them that the supplement was a white powder, and the patient mixed it with hot water and then drank it. And I couldn't find the original photo of the packet, but it was something. It was it's kind of similar to the picture that was here. And so go in, examine the patient. So know that the patient was afebrile. Their vitals are basically not concerning at all. The interesting thing in terms of her exam was that she was awake, she was looking around the room, but she wasn't talking, wasn't making any noises. She didn't have any apparent rashes, didn't have any apparent signs of trauma to her head. She had pupils that are 5 millimeters, but otherwise no other abnormalities. The other notable thing on her exam is she had some increased tone in her neck, kind of extended with her chin out, and then she had what we refer to as a rhisis sardonicus grin, or what we also kind of refer to as trismus, and kind of like basically teeth clenching. The rest of her exam was just noted that she had increased tone throughout her body, a little bit tremors, but appeared to be moving everything. And so at this point, as the question was the supplement the thing that was causing her presentation, or was that just a red herring and something else was going on? And because the envelope or packet, the supplement, there was no English on it. And so we unfortunately couldn't immediately kind of look at it and say, oh yeah, this could be, or no, this is probably not the cause. And so at that time, my differential was pretty broad. And so the question was like, is this a seizure, an epileptic seizure because of the increased tone and stuff? Did she have a spontaneous brain bleed, or maybe had some head trauma that we weren't aware of? Does she have a mass in her brain that's causing this? One thing that I was thinking, and probably would have only thought of because I'm a medical toxicologist, was, is this strychnine, which we'll kind of talk about later. Could it be an illicit drug toxicity, so amphetamine or cocaine? Is it serotonin toxicity or neuroleptin-Malignant syndrome? We didn't know what kind of medication she was taking. And so that was sort of up in the air in terms of, is this a medication adverse effect or adverse event? Could this be a tetanus infection because of this finding of Rhesus sardonicus, which is sort of classically associated with tetanus, but can also be found in a lot of other conditions? Was it just a urinary tract infection that was causing her to be really confused? And so at this point, kind of casted a broad net, kind of check a bunch of labs, get some CT scan, get a urine drug screen to kind of see if there was any evidence that she had been exposed to an illicit substance. But strychnine was also kind of up there in terms of her differential. And part of it is because she had taken this herbal supplement that would be considered like a traditional medicine, and strychnine historically has been used for that purpose, and could also be present as a contaminant in the supplement that she was taking. And so got some blood work. Her blood counts, electrolytes overall were pretty normal. Her creatinine kinase level, which can be elevated in the setting of muscle damage, was not very high. It was something like 500. Her urinalysis did not show any infection. Her CT head without IV contrast was negative for any bleed, skull fracture, mass, that kind of thing was completely normal. And so the question is, what was on the UDS? And then we also ended up sending off a comprehensive toxicology screen. So before going to the results of the UDS, the treatment that we kind of gave her was IV fluids. I gave her a couple of doses of benzodiazepines to kind of help with relaxing her muscles, and she was getting a little bit agitated. And then we admitted her to the hospital for further monitoring and treatment. And so now you're wondering what was wrong with her, right? And so her urine drug screen actually ended up being positive for amphetamines. And the comprehensive tox screen showed that the specific amphetamine that she was exposed to was Ecstasy. Kind of thinking after with that result in hindsight, it's like, no, her exam actually kind of made sense. So the clenching and teeth clenching, she was probably having bruxism, which is a common exam finding associated with ecstasy. And the way that she was behaving was likely that she was having some hallucinations. And given that she probably unlikely uses ecstasy on a daily basis, or probably ever, probably just didn't, that was the way that she was kind of responding to what was going on. We are still waiting on the results for testing the packet itself, and that's more to see if this was a contaminant in the supplement itself, or whether she was potentially exposed after she had taken it. After family had arrived, family said that they were concerned that the cousin that she had been staying with, he uses cocaine, so maybe other illicit substances, and somehow maybe the patient had been exposed to that. So I'd be lying if I was disappointed that it wasn't strychnine. I think strychnine would have been a much cooler diagnosis because it's something that's really not seen anymore. So I was a little bit bummed out about that, but at the same time, it was probably overall better situation for the patient because ecstasy is probably a lot more benign than strychnine. So the question is, what is strychnine? So strychnine is an alkaloid toxin. It's derived from this plant, Strychnos nux vomica, which you can kind of see an illustration of right there. It's a plant that was used in herbal medicine. It's thought to help with a whole host of different illnesses, just like most herbal medicine remedies are. They give it for everything. But historically, in terms of what it's actually been used for, it was actually used as a rodenticide. So that's probably not a good thing to be exposed to if you have something that is been used as a rodenticide. And the thing about strychnine is it's very rapid in onset. So usually within like 30 minutes to an hour or two. And so the toxicity from strychnine, the way it works is that it's a glycine receptor antagonist. So your glycine receptors, glycine is a main inhibitory neurotransmitter that's located in the spinal cord. And so strychnine mainly acts in that location. It does not cross the blood-brain barrier. And this basically reduces the amount of inhibition in the spinal cord. And so this causes diffuse muscular contractions and seizure-like activity, but the patient actually is not seizing because their mental status is sort of maintained. Going back to this patient, that was one of the things I was kind of going against, that this was strychnine toxicity, because of the fact that she was not quite with it. She was definitely confused, maybe hallucinating, but something that I've learned going through medical toxicology fellowship is that nothing follows a classic picture, and you can get overlap with a lot of different things. And even though we learn about stuff and say like, oh, if it's this set of symptoms, it's this toxidrome, or it's this set of symptoms, it's this toxidrome, you can get a lot of overlap. And so just because something doesn't quite fit the classic picture doesn't mean that is completely ruled out. And basically the concern is with this uncontrolled muscle spasm tremor, those patients can get hyperthermic, you can develop severe rhabdomyolysis. And so when these patients present, they'll be completely conscious, they'll have a normal mental status. You'll get facial trismus and your rhisis sardonicus grin. And then typically in terms of their exam, you'll see that they're mostly flexing their upper extremities, so their arms, and then their legs are sort of extending. And the patients can also be hyperreflexic, they have clonus on neurologic testing. And so treatment for this, if patients are presenting early, so not symptomatic yet, then activated charcoal has been shown to prevent or bind strychnine very effectively and prevent toxicity. The other main treatment is minimizing external stimulus. So lights down, reducing the amount of noise that the patient is exposed to, and then benzodiazepines if they are having severe muscle spasms. In severe toxicity, if they, despite with benzodiazepines, if they are still having a lot of muscle contractions and they have severe rhabdo, administration of a paralytic may be necessary. But if you're giving a paralytic, then those patients will need to be intubated and put on mechanical ventilator for that time. The thing that patients will ultimately succumb to is the severe rhabdo and hyperthermia. So it's really important that you address those things if they do have that. So hyperthermia being, you would cool them with like ice and ice packs and that kind of thing. And then rhabdo is treated with IV fluids and making sure that their urine output is maintained. So definitely would be much more interesting than ecstasy, but unfortunately a little bit of a bummer. But the last thing I want to talk about, it's not a case, but because addiction medicine is sort of one of my interests, I just want to talk about terminology and words that you use when you are talking about these patients, because I think it's really important in terms of making sure that these patients are treated appropriately in terms of their medical care, because whether we know it or realize it or not, we all have internal bias of some sort. And unfortunately, some of this bias comes out and will influence the kind of care that we give to patients who do use, who have substance use disorders. And so dealing with a patient that has a drug use disorder or substance use disorder can be difficult. A lot of times these patients don't want to open up to you. They don't trust you. And so it's really important to develop a rapport with these patients so that you can actually give them the medical care that they need. And so in the past, you've probably heard these kind of terms. People refer to as drug addicts, junkies, drug abusers, ex-addict, that they are non-compliant or failed rehab. And all this stuff has really negative connotations and really can influence how somebody else who is going to be treating that patient when they read your chart and like what you document or how you talk about a patient when you're giving sign out to somebody else, that can influence that other person and potentially to the detriment of that patient affect their medical care. And so when you find yourself in these kind of situations, instead of using these kind of what I would consider like old terms, consider using the ones on the right. So any patient that uses drugs, refer to them as somebody who has a substance use disorder, not an addiction. That somebody who's an opioid use disorder specifically, person who uses IV drugs, not an IV drug abuser or IV drug abuse is something else that you'll often see people write. An ex-addict, you should refer to somebody who's living in recovery. In terms of like using terms like detox, this is something I found is very hard to really change people's because everybody uses this term, but it really should be like withdrawal management. And then people who have addiction are not suffering, they're living with addiction. And so using the appropriate terms can help make sure that helps you take a step back and really think about that these people are human. And despite the things that they've gone through, they deserve to have the same level of care that we might give to somebody else who doesn't have a substance use disorder. Addiction is a disease, not a choice. As I know that some people will debate this, but addiction is a disease. And a lot of times a lot of these patients, they want to stop, but they aren't able to because they don't have the resources or help that they need to be able to stop using. And like I mentioned, the language that you use can influence the care that you give the patient, subsequent care that that patient will receive from somebody else, as well as what the patient might be open to. Because if you use the wrong terms, your rapport with that patient is going to be not as good. And so they may not be as open to trying new treatment or whatever the situation might be, or staying in the hospital if they have an infection, those kind of things. And so I wanted to kind of just put that in there in my presentation to kind of emphasize that. So just to kind of conclude, so medical toxicology encompasses a lot of aspects of medicine and requires a very detailed knowledge about pharmacology, pathophysiology of like many disease processes and how different medications and toxins and things like that work. I think it's really interesting, particularly if you have an interest in things like organic chemistry, biochemistry, those kind of things. This might be a field to kind of consider if you do end up going into emergency medicine. So to become a medical toxicologist, you need to complete medical school, obviously. That's 4 years. You'll do typically emergency medicine residency, because emergency medicine or medical toxicology is a subspecialty of emergency medicine. And so that'll be either 3 or 4 years, depending on which program you choose. Fellowship is then an additional 2 years. And then you would go on to then get board certified in emergency medicine as well as medical toxicology. Becoming MedTox trained can open up a lot of opportunities outside of your traditional academic medicine realm, whether it's in industry, consulting, and things like that. And then again, just to kind of emphasize about for addiction medicine and those patients, be mindful about the language and really just any situation. Be mindful about the language that you use around patients because this can impact their care from you, from others, as well as what they'll allow or what kind of care they'll be open to getting. So you can feel free to reach out with any kind of questions or anything. This is my email address, richard.chen@jefferson.edu. And then this is my Twitter at rchenemtox. With that, I can take any other questions.
Absolutely. Well, first of all, thank you so much, Dr. Chen, for getting this all together. I personally learned a lot from the cases. You mentioned chelates, did hit home back for organic chemistry. Gave me some reminders of organic chemistry and biochemistry and studying for the MCAT. So it does play a role later on. That's reassuring to know. We just have maybe two questions we can go through now that we're almost at the end of the hour. We're a little past the end of the hour. But the first one being from case one, you mentioned anion gap. Would you mind clarifying what an anion gap is?
Sure. So whenever we're looking at trying to determine what is the cause for an acidosis, anion gap is basically where we look at your sodium or chloride and your bicarb, and then basically seeing what that difference is. So normal anion gap is typically somewhere around like 8 to 12-ish. But basically you have your sodium. Oops. So your sodium, your bicarb, and your your sodium chloride and your bicarb. And so you basically take your sodium minus your chloride and your bicarb, and then that's what your anion gap is. And so what this shows is that basically the anion gap is a measure of anions. So chloride and bicarb being your typically measured anions. And basically it tells you, is there some other anion that's not being accounted for that could be causing the acidosis? So things like lactate. I mean, lactate is probably the big one that we look for, and like other potential like chemical exposures that may show up in the serum, but that we don't necessarily measure directly. And when there is a gap, it means that there's something else that's not supposed to be there that you're seeing, and you ultimately probably will never get or find out what that is. But it can be indication that that patient has something going on that they're trying to compensate for. But that's essentially what the anion gap is.
And one more last question. You mentioned medical toxicology being a fellowship after emergency medicine residency. Would you mind taking us through a couple other fellowship options? What are some other routes after residency?
Sure. So in terms of emergency medicine, so probably the other big ones would be EMS, ultrasound. There's also education. I know that there have been a couple of newer ones that have popped up, but I think sports medicine is another one. Those are probably the main ones that I'm familiar with that I've heard about. I think there's a few other ones, but if anybody wants to see what kind of fellowships are available, they can Google EMRA, EMRA, and then fellowship guide. So EMRA is the Emergency Medicine Resident Association. And so they sort of like a booklet online website that kind of goes through what each subspecialty is, what the requirements are, how to apply, and all that stuff. So I think there's a few other ones aside from the ones I listed.
Yeah, they're definitely growing over the past years. There's new ones popping up. So that's good to know that medicine is evolving that way. But that will wrap up our session. I do have some last reminders to those listening in. So if you would like to earn credit for your attendance, we have a quiz that's posted in our chat, the same chat that we have with our live streams in general. And then it's also posted in our description of the video. And the third place it's posted in is our website on our virtual shouting page. We have a couple pages, but just make sure to hover and click onto the virtual shouting page. You'll see it if you scroll just a bit down. It should be on the left-hand side, marked Monday, Dr. Chen, and then the due date, which will be June 11th, this Sunday at 11:59 p.m. Central Standard Time. So just be sure to complete it by then. It's just 10 questions, and you have to complete or get correct 6 or more to pass. And once you do pass, then you will receive the certificate that will be sent to the inbox of the email address that you list. We do recommend that you list a Gmail, a Yahoo email, or another personal email address, just so it doesn't filter out to spam. But in case you don't get it through to your inbox, please do check your spam folder. If it does not go to either, please do go ahead and email us. Feel free to email us. I have the email in our description if you have any questions or if you run into any problems with receiving the certificate. And for our next shadowing session, like I said at the beginning of the session, we do have sessions on Mondays and Thursdays. So our next one will be with Dr. Young. She's an ophthalmologist specialized in cataract surgery, and we'll see her at a regular time of 7 p.m. Central again this Thursday, June 8th. We'll be continuing with more shadowing sessions in the weeks to come. We're very excited to be seeing all these new specialties. Medical toxicology is actually the first time, it's been the first time that we've seen medical toxicology. So that's very exciting. I think we had a few emergency medicine shadowing sessions, but seeing subspecialties is always new. And then, like I said at the beginning, our Instagram page and our email listserv, those are two great ways to stay in touch with us. We do have a couple programs that will be launched at the end of this summer. So around July to August, to do with our mentorship programs, to do with our volunteering programs. If you'd like any details on that, feel free to email us. But I do recommend before emailing us to go onto our website where we have descriptions of each program and you can look through what they entail. But that is all. Dr. Chen has his contact here. Feel free to shoot him an email. I really do appreciate you for dropping your contact in. It's always helpful for students to reach out. And let's hear some thank yous in the chat for Dr. Chen. This was a wonderfully made presentation. I loved hearing about the field and especially the cases, seeing how, like I said, biochemistry fits into medicine is really reassuring to know for us students who are going through that phase of study. But that is all. So thank you again, Dr. Chen, for taking your time with making this presentation, with presenting today. And I will see all of y'all on Thursday. I hope you enjoy the rest of your week. Take care, guys.